All right. Good evening, everybody, and welcome to another NCAN live streaming Q&A. Today, we are going to have the one and only Dr. Aman Chauhan here, part of the NCAN family. But I do need to get some light housekeeping out of the way. First off, very important, our next conference is September 21st, New Brunswick, New Jersey, the Morris Cancer Center. It is it's on Rutgers University campus. So it's going to be another great day of amazing presentations. We have a bunch of panels actually set up. It's going to be really awesome. So September 21st, we just opened our Strides for Stripes virtual walk. That just opened today. It's a neck cancer walk, and you can do it from anywhere. So we also have our monthly support group meetings. We've got a bingo night that we're going to do. We've got some other really great fundraising opportunities and events coming up. So please go over to netcancerawareness.org, go to the upcoming events, and you'll be able to get all the information you need on that. I also do want to thank our sponsors for this event. Down below, you can see all of them. Without their help and support, things like this would not happen. So, Dr. Chauhan, you got your scrubs on, so you must have just gotten in. We've already got a bunch of questions. So, I mean, what do we say about Dr. Chauhan? He's the leader of the NET tumor program at Sylvester Comprehensive Cancer Center at the University of Miami. He is also the co-director of their theranostics division. He is now on the board of NANETS, which, for those of you who don't know, that's the organization that teaches all the doctors all about NETs and stuff. They're very, very important to this process. They keep them informed. Thanks for joining us. Very busy. How are you?
Thank you, Mike. First of all, it's always a pleasure. I've kind of lost track of our association, my association with NCAN. Probably one of the first group in the NETS arena that I collaborated with. And I think it's been now several years, maybe close to a decade, that we've been doing a lot of cool things together. So always great to kind of hang out with you and the whole Woman family and the NCAN family. Yeah, life's been busy, but busy is good. It's been a blessing. Thank you. I was recently inducted into the NANETS board. Very grateful for the opportunity. We have seen a huge strides in terms of advances both in diagnosis and management. And anybody who is associated with your community will attest to it, that you take back 10 years back and where we are today in terms of the number of treatments, how sophisticated we've gotten, the amount of treatment options, as well as our understanding of neuroendocrine cancers has improved several folds. I remember when I was a resident at LSU with Voltring and Wang and Boudreau and Dr. Ramirez, there were times where we had patients, we had to send them to Europe to get PRRT, right? And moving fast forward almost a decade, I have patients who routinely see me from Europe for an opinion, for a clinical trial. Things have turned around. We made tremendous strides and progress. And this is just exciting time to be associated with neuroendocrine oncology. And big kudos and hats off to patient advocates and advocacy groups like yourself and several others in the field who's really helped us create that momentum, raise awareness, and provide really good information, high quality information to patients, in a timely fashion. Because usually back in the days, cancer was all about common cancers: breast cancer, colon cancer, pancreatic cancers, lung cancer. And people forgot rarer cancers like neuroendocrine tumors. We changed that together with all our advocacy efforts. So we look forward to continue to build on the work. We still have far way to go. We haven't cured this disease yet, right? So that would be the ultimate goal, that one fine day we find a cure for neuroendocrine cancer.
Yeah, absolutely. So you've had a long day at clinic today. Are you ready for some questions from the comments here?
It's always good to kind of address Q&As. Just a caveat, I'll try my best to address the questions, but please don't consider this as medical advice, because a lot goes into giving patient-specific medical advice, understanding their disease, reviewing their records, etc. Think of me as a friend, your friend here who is just sharing his experience or understanding. But please don't take it as a gospel truth. Please discuss your individual case with your oncologist. Okay.
Yes, and also, yeah, let's not get too granular with these. We're not going to be going over scans and stuff like that. So we're going to try and keep this pretty rapid fire. We usually keep it to around about an hour. So we're going to get to as many questions as we possibly can. First one is from Sunshine Shigigi, I think.
That's a cool name.
I have a neuroendocrine tumor on my skull. Can I go on Disney fast rides?
Oh my goodness, that's one of the most challenging questions I've recently. I was actually just at Disney, FYI, last week, and so I would definitely not want you to miss the fun rides at Disney. Now, a tumor on the skull is probably less problematic as compared to, let's say, if you had a tumor on the spine, and especially on a critical, area in spine like neck, right? Because any fast, jerky movements, so you have to stop immediately, or you kind of speed up immediately, put some pressure on the spine, and you can certainly, theoretically at least, at risk of fracturing, right? But here we are talking about the skull, which is relatively safe from the spinal cord standpoint, and again, in my opinion, I think it should be okay. But again, this depends on your case specific details, like the patient had a surgery, was there a reconstruction done? Usually not the case. I'm just talking about the standard presentation. If somebody has a bone met on the skull, should probably not be a problem. I can't anticipate there would be a major issue. And now, if this was another location like spine, I would be careful. I would say, hey, can you get clearance from your orthopedic spine doctor? See how much physically strenuous activity you should be involved in, and what is your limitation. But I think Disney fast ride should be okay. But please do consult with your local oncologist.
Yes, they actually did chime in too, and they said they have a tumor on the spine too. So yes, make sure you cross your T's and dot your I's. Consult your local doctor for sure. We have another one, Jeff Friedman, G3PNet, going on 16 years. Have gone through all the standard modalities. I'm now on Lenvima for a second time around. Lenvima. For the second time around. What should be considered after this? My KI 67 is 49%. TB at TMB. 11. I'm sorry, yeah, TMB at 11. FOLFOX.
All right. Yeah. So again, grade 3 NET, one of the rarest subset of NET. There are 3 grades, just for everybody out there. Grade 1, 2, and 3. 3 is the rarest of all 3, and also relatively more aggressive. Having said that, you can't generalize for individual patients. So Mr. Friedman here has a long-standing history, 16 years. So clearly not like a typical grade 3 presentation. Could have also evolved over time. Now, because it is the reason why I'm priming with the fact that it's relatively rare, or also most recently recognized subset of neuroendocrine tumor. Before 2016-17, we didn't really know there was a grade 3 NET. Everything which was grade 3 used to be considered poorly different neuroendocrine carcinoma, and everything below Ki-60 20% was a grade 2. So this is a relatively newer subset. And why is it important? Because when you have a rare disease and relatively new disease, the treatment options somewhat limited as compared to commoner diseases, commoner subtypes. But we have made some progress in studying this more aggressive grade 3 well-differentiated NETs. For example, cabozantinib was recently FDA approved, I think in February this year, and that the clinical trial that studied cabozantinib included well-differentiated grade 3. So I'm not sure if Mr. Friedman has had cabozantinib, but he's on Lenvima, very similar type of drug. So it's a possibility he might have had other TKIs exposed as well. Clinical trials is my usually go-to when I hear and progress through all standard treatment. Now, I don't know what all standard treatments Mr. Friedman is implying. Has the patient already has carboeto, FOLFOX, FOLFIRI, there are some of the IV chemotherapies that we oftentimes use in high-grade neuroendocrine tumors. So those would be all fair game. Tumor mutation burden is a very important data, and I see that it's 11 that would qualify the patient for immunotherapy on label. This is not even off label. So Keytruda is FDA approved for tumor mutation burden intermediate or high for any cancer, and I've seen some really good results in certain cases. So these are all standard treatments, including IV chemotherapy regimens, IV immunotherapy regimens. But I would really look hard towards clinical trials at this stage. Grade 3 NETs, for example, we have a clinical trial for grade 3 well-differentiated neuroendocrine tumor at University of Miami, where we are injecting an oncolytic virus called Seneca Valley virus, which seems to have anti-tumor activity, especially for neuroendocrine cancer, especially for higher grade 3s. So we inject that virus directly into the tumor where it grows and thrives and literally destroys it from inside out. When it destroys the tumor, it releases the tumor antigen, what we call neoantigen. And we pair this oncolytic virus with the standard immunotherapy called Opdivo and Yervoy. These are standard of care immunotherapy, very, very commonly used for melanoma, kidney cancer, bladder cancer, but by itself has not really worked out so well in neuroendocrine tumor. So what we are trying to do is we are trying to make these well-different neuroendocrine tumors also respond well to standard immunotherapy by injecting this oncolytic virus, causing that inflammation, causing that neoantigens to release, priming your immune system to then work against all the tumors. So it's kind of acting like fuel to the fire. So that study is up and running and is already enrolling patients. That would be a great option for a grade 3 well-differentiated neuroendocrine tumor. But sometimes logistics is an issue. Not everybody can travel to Miami. You might be a little far. There are other issues. So I would highly encourage you to look for other clinical trials who might be geographically closer to you. One of the resources is clinicaltrials.gov. You go to this government-maintained website and you type in pancreatic neuroendocrine tumor or neuroendocrine tumor and use the search filters where you kind of only look for active enrolling studies, not something that is already closed, etc. And then you'll get a big list. And you go through that individually, see, okay, where is this trial open? If you are in Alabama, is this closer to me? If you are in West Coast, is it California, Washington, etc. So it gives you location. It gives you what kind of trial it is, what drug they're using. It gives you the indication. Is it a neuroendocrine tumor trial? Something else. So you can certainly refer to clinicaltrials.gov and screen some of these clinical trials there. But I would highly recommend at this point for a rare disease, when you have been through all the conventional treatment, that definitely look hard into your clinical trial options. And these options are always evolving as we are developing new drugs. There are always new options. And last but not the least, I can't tell you for sure based on this question that what all standard treatments have you had exhausted. So if there are some standard treatments left out, that having an opinion from a neuroendocrine tumor specialist, you might be able to revisit some of the options that might have been either missed, overlooked, or have just now a new option in consideration for grade 3 NETs.
Great, great. Next question we have from Christine Mayer. It looks like alpha PRRT will be my next treatment. What can you share about the side effects, success, things consider, etc.?
Great question. So PRRT, we've heard a lot about this in last 7 or 8 years or so. Really game changer of a treatment when it comes to neuroendocrine tumor. Why? Because it's a targeted way of radiating your tumor, right? So if you have cancer that is all over the place, bones, lymph nodes, liver, you can't just go in and radiate it in the conventional way. So some smart people have designed a drug that is radioactive. You inject this, it goes and finds wherever the tumor is. And it is able to do that because these drugs are designed to latch onto somatostatin receptors, which are found in neuroendocrine tumors. So you do a DOTA-8 PET, these drugs get, if you have somatostatin receptor positive tumor, it lights up on DOTA-8 PET, which qualifies you for these treatments. And you inject the drug, it goes and binds to the receptors. The drug itself is radioactive, so it's carrying that radiation to the tumor, and then it radiates the tumor. Now, all great. And one of the first drugs, the only drug that is currently FDA approved in this class in the United States is called Lutathera. It's the PRRT agent. It's a type of beta PRRT. Beta PRRT implies the type of radiation, type of ionizing radiation the drug is emitting into the tumor and causing it to destroy. It's the physical nature of that radiation. It is successful, works really well. Hundreds of patients get treated every year, and it's been a big game changer. The next wave of PRRT drugs that are currently under investigation are alpha PRRT. Okay, alpha PRRT doesn't mean that it's better than beta. It's just a different type of ionizing radiation. Okay, it's an alpha ionizing radiation, which has distinct physical characteristics as compared to beta ionizing radiation. For example, it is high energy and it has low penetration. So what happens is, because of its high energy, it is able to cause double-stranded DNA breaks as compared to what we feel the beta ionizing radiation causes single-stranded DNA break. That doesn't mean that single is better than double or better, So these are just the physical properties. And I want the viewers to understand these are just two different types of PRRT. Now, alpha can be given, there's these radiopharmaceuticals, lead-212 is under development in the clinical trials, or actinium-based. And it is very early in the development. That means it's not that we've treated patients in the United States for 10 years and we have a lot of long-term follow-up data, but there are some very good clinical trials that are testing these class of drugs. Now, to get to specific question by Christine, what do we know about, let's say, success? So the preliminary data from alpha PRT studies, these are phase 1 studies and phase 2 studies from last 2 or 3 years, suggest that they are very effective. A lot of disease shrinkage, perhaps more than what we notice by beta PRRT. Okay, so in terms of just disease shrinkage, if that is the measure of our effectiveness, it clearly seems to be a lot more active. The response rates, that's the scientific terminology of the degree of shrinkage or how many patients show shrinkage after PRRT, it seems to be more with the alpha PRRT. But I want to remind the audience that at the end of the day, what truly matters for us is, are the patient living longer and is the disease stable for longer? So it truly doesn't help us if the tumor shrinks a lot, but also then grows very fast. Okay, and I'll give you an example. There are 2 studies, NETTER-1 and NETTER-2. NETTER-1 study tested Lutathera or PRRT, beta PRRT, in a slow-growing, indolent grade 1, grade 2 NETs. And the response rate was about 18%. So most patients did not show shrinkage. Most patients showed stability, but the stability lasted somewhere close to 28 months. As compared to Netter-2, same drug, but in more aggressive patient population, grade 2 and grade 3, more higher grade tumors. The disease shrinkage, the response rate was pretty high, I think close to 40%, 40, right? So big time shrinkage, but the median time to progression was much shorter, is in, I think, somewhere early 20 months, right? So the response rate sometimes could be because of the type of disease we are treating rather than effectiveness of the drug itself. So while on face value, alpha PRT for the time being seems to have more robust responses, more disease shrinkage, but what we have yet to see is the longevity of response or durability of response, or how long is the progression-free survival or median PFS, okay? Those answers has not yet been answered, and those trials are currently ongoing. We are certainly optimistic. We are always want to push the limits and improve on what we have currently, right? So good drug, good clinical trials that are currently testing alpha PRRT. I would highly encourage, if you are a candidate, consider this. I think there's a good science behind it. But like any trial, just know it's a trial. We don't know fully how good it will work. Would it be better than beta? Would it be worse than beta? Or would it be equivalent? Secondly, about side effects. We are learning it has very unique side effects as compared to Lutathera. One of the good things about Lutathera or beta PRRT is we have a lot of comfort in because we have been treating hundreds. I personally supervised treatment of over 300 patients by now since this FDA approval, and not hundreds but thousands of patients have been treated in the US. And not only that, we have almost 7-8 year long-term follow-up data of these patients. So we have a lot of comfort in knowing that, okay, how well these medicines tolerated. It doesn't really affect kidneys and bone marrow and liver. The risk of leukemia is very small, is 1 to 2%. Risk of MDS is less than 4%. We understand all these risks. It's not 0%. We understand these are, non-trivial risks, but they are relatively rare and most patients do very well. Those long-term safety signals are yet to be again studied. But in short term, we have tested these drugs and we have phase 1 data and phase 2 data. So I can tell you, again, very similar to Lutathera, most patients tolerate these treatments very well based on the published data. Patients do tend to have more hair loss with alpha PRRT as compared to beta PRRT. Some people may have some dry mouth issues. Anecdotally, kidney problems could be something that needs to be washed out. But for most patients who have had good kidney functions to begin with, should be okay. But if you have renal insufficiency or some sort of kidney problems at the baseline, that's something that I would caution that needs to be watched closely. But that's true for any PRRT drug, regardless of alpha or beta. So all in all, very reassuring safety signals to date, but these drugs are still under clinical trials. They're not ready for the prime time yet.
Great. Now some more questions about the arrows in the quiver. Stacy Dunk is asking, what can you share about lanreotide versus octreotide versus standostatin? Is one preferred? How does one get the correct dosage / administered properly? And how do you know when you should begin the shots?
Great question, Stacy. First of all, these drugs that you mentioned, lanreotide, octreotide, sandostatin, these are all somatostatin analogs. Okay, and they're basically the same. Okay, lanreotide and sandostatin are long-acting form of octreotide. That means if you get an injection of lanreotide or sandostatin, it will stick around longer in your body. That's why you get it once a month. Short-acting octreotide is the same drug, but it's a short-acting. So that means when you inject it, it doesn't last long in your body. So you need to get it injected multiple times a day, every single day, for it to have the consistent levels in your body so that it can control the tumor growth or control your symptoms. So initially, when we didn't have lanreotide or sandostatin, octreotide is what was first discovered and was used. But very soon, you can imagine our patients live long for several years, sometimes several decades. So if you have to inject yourself 3 times or 4 times a day for every single day of your life, that's quite a task. So this is where there was a necessity of, can we develop a long-acting formulation, long-acting release? And sandostatin was the first one in the market, where you inject. It's a deep intramuscular injection. You get it in once a month in your butt, and it's a depot injection. So we get the drug injected. It kind of slowly releases from that muscle over the next few weeks, and there's a consistent level of the drug in your body. To follow up on that, lanreotide came into the market. It is a deep subcutaneous, so you don't necessarily have to get the injection all the way deep into the muscle, but it's also not superficial. It's a deep subcutaneous injection, and it's a gel formulation, but very similar concept. Once you get that injection, it slowly releases from that deep subcutaneous tissue over the next several weeks. So you have a consistent monthly level of the drug. So you don't have to get these injections again and again. So in my mind, they're all doing the same thing. They're all somatostatin analogs, right? In the current era, we don't necessarily need to give octreotide outside a rescue shots where you have a bad day and you need some extra, so you get some additional shots. For most other cases, for tumor control or symptom control for carcinoid syndrome or VIPoma, you're going to get either monthly lanreotide or monthly sandostatin, and they're both equivalent, tomato. Some doctors have preference to one versus the other. There's no clear winner. They're both good drugs. Okay. Sometimes one patient tolerates one drug better than other. So if you're having some side effects with one brand, you can try to switch and see if that side effect dissipates. Regarding the dosage, administration, well, in Europe, lanreotide can be self-administered, but in US, it's not FDA approved for that. You have to get it administered through a certified healthcare provider, nurses usually, and they are trained to inject these things. So fortunately, you don't have to inject it yourself. You'll hopefully have a certified nurse or somebody who knows how to give either deep intramuscular injection if it's sandostatin, or deep subcutaneous if it is lanreotide. Having said that, I do want to caution you. There was a study done at MD Anderson that looked into how effective, or not effective, but how accurately were these injections being administered. So patients were getting these injections, and then they were getting scans to see if the injection landed at the right spot. For example, sandostatin is a deep intramuscular. Were nurses giving it into the muscle, or were they missing it? And there were quite a few occasions where they were missing it based on the published publication from Boyd. So it's very important that the person who is administering it is well trained. That if it's sandostatin, needs to go into the muscle, the gluteus, and so that it's absorbed to the fullest potential. Lanreotide doesn't have that issue because it's a deep subcutaneous. You don't really need to get the needle all the way to the muscle. You just need to get it somewhere in the deep subcutaneous tissue. So that's maybe a small advantage there. But that doesn't mean there's no head-to-head data that one drug is better than another. Okay, so all you need to know is make sure you're going to a facility where the nurses have been trained. These are pretty standard stuff. They should know how to give these injections. Okay. Regarding the dosage, lanreotide is pretty standard. It's 120 milligram once a month or every 28 days. Sandostatin, the standard dose, anti-tumor dose, is 30 milligram. However, there is some flexibility there. We can go up or down on the dose. Some patient, because if they have some side effects with pancreatic insufficiency, you want to cut down the dose, you may have option to do 20 milligram as well, but the standard was usually 30 milligram, and vice versa. If 30 is not cutting it, sometimes you go up to 40 milligrams, but the standard dose would be 30 milligram for sandostatin. I would finish off with saying that there are a couple of more other drugs that are in development. One of them is a subcutaneous, which patient would be able to administer themselves at home every 2 weeks if the trial turns out to be positive and the drug gets approval. So there are a lot of ifs and buts, but there is definitely a demand from patient community sometimes that, hey, doc, can I give myself something under the skin like insulin shot and don't have to go for once a month injections? I myself hate big injections like a tetanus shot. So I can empathize with patients who may need injections for several years. And then there is another drug, which is a pill form of somatostatin analog, that the phase 2 data looked very promising and is going to be now tested in phase 3. So, but these drugs, we are talking, few years to several years in development, but at least something positive that we probably have more options in future beyond just the injections.
Great. Awesome. Jeff Friedman chiming in again here. SBRT a consideration for liver mets? Have already used PRRT in the past, if you've used PRRT in the past. Okay.
Right. Good question. Usually, I try to avoid external beam radiation in the liver, especially for well-differentiated neuroendocrine tumors. SBRT, we use it very, very commonly. In fact, I just sent a patient. It's a lung met patient. So for lungs, great. In pancreas, if it's not a resectable patient, I've used it. What happens in the liver, there's no clear way to just target tumor, because think of liver as a big organ and tumor is sort of peppered throughout in the liver in this three-dimensional organ. So when you target the tumor, there will be some collateral damage and normal liver tissue will either come in the path of that radiation. So then the question comes is the risk versus benefit. So if there was a tumor that there is no other way to, is causing problem in terms of symptoms, big tumor expanding rather fast, causing a lot of pain, pressing on stomach, causing appetite issue, and you really need to shrink that one particular area, usually we would do interventions like liver-directed therapy, Y90, TACE, bland embolization, in some cases surgical debulking, good. But we oftentimes don't use external beam radiation or SBRT in those cases because we worry about collateral damage. I have done it in higher grade cancer, especially neuroendocrine carcinomas, because they are very radiosensitive and it is done as palliation. So those tumors can grow very fast and radiation can shrink the tumor, giving a lot of pain relief to patients. But for well-differentiated neuroendocrine tumors, which are relatively not as radiosensitive, and we have better modalities to target liver in terms of embolization, ablation, and in some select cases, surgical resection, we oftentimes don't use, SBRT is not a typical mainstay. But for case by case, if that's the only way to tackle a problem area in the liver, and it is symptomatic and is causing some critical mass effect in that area, maybe on a case by case basis be considered, but not a norm.
Great. We have a question here. I'm gonna, it's gonna be hard to just give you a real yes or no answer here to freedom here. Hi, my wife has a tumor in the liver. She received chemotherapy. Do you think that the chemotherapy reduced the tumor? Very hard question to answer.
Yes. So it's a good question in terms of, we don't have a lot of specifics. So one of the things about neuroendocrine tumors is it's very nuanced. And that's the challenging and also most interesting part of it. So when we say we have tumor in the liver, different tumors would behave very differently. A grade 1 tumor would be very different than how I would approach grade 3. Within grade 3, as you heard from one of the colleagues here, Ki-67, if it's 20% versus 70%, I would approach it completely different in terms of the type of chemo that I'll use. So the effectiveness of the chemotherapy varies on all these factors that we discussed. What is the grade of the tumor? What is the type of, it's a well-different NET, what is a poorly different EC, etc. Having said that, for more aggressive cancers, higher grade tumors, especially grade 3, they tend to do respond to chemotherapy. So chemotherapy is one of the mainstay of the treatments. Higher the grade, more we gravitate towards the chemotherapy. Pancreatic neuroendocrine tumor is another unique subset of neuroendocrine tumor, which is very responsive to certain select chemotherapies like CAPE-10. So not all chemotherapies or chemotherapy is not an answer to all NETs. So if I have a mid-gut, low grade, grade 1, small intestinal NET, usually chemotherapy is not very effective for those tumors. But if we are dealing with the pancreatic neuroendocrine tumor, CAPE-10 is a very effective option. If you're dealing with the grade 3 neuroendocrine tumor, chemotherapy is a very effective option. So yes, the tumors can respond drastically to chemotherapy based on what type of tumor we are dealing with. And I'll give you a case in point. So if you Google CAPE-10 and pancreatic neuroendocrine tumor, there are a few publications. One of the older publication is from Jonathan Strasberg in, and there are patients that they have reported complete response. The tumor completely disappeared. I personally had patients where patient had complete response or near complete response. A big giant tumor turned into a 0.5 centimeter tumor with CAPE-10. But that doesn't mean all subset of neuroendocrine tumor will have equal response to the chemotherapy. So yes, in theory, yes, chemo can work, but you have more finer nuances what subtype of neuroendocrine tumor we are dealing with.
Perfect. I do want to just let everybody know we will answer all these as they come in the order they come in at. So please, Aman likes to be pretty thorough with this stuff, so we will get to all these questions for sure. Carol Dennis is saying, I would like an experienced NET specialist to review my imaging. Is it possible to do this from out of state via telemedicine visit? Would this be with you or with a radiologist? How would you go about arranging that?
Yes, so thank you, Carol, for that question. Yes, we as NANETS, as from the society standpoint as well, we highly recommend to, at some point in your treatment, that you do touch base with one of the NET specialists. And in some places, these NET specialists are oncologists. Some places it could be a surgeon, and other places could be an endocrinologist, but most places it's usually a medical oncologist. So you don't have to go see a specific radiologist to get your scan reviews. You just go for a second opinion to the NET specialist at a location which seems convenient to you. There are several websites that can guide you in terms of state-wise breakdown of the NET specialists in different states. There are very few places now which has nothing. Most states do have some NET specialists available to them, so you might not even have to go far. As far as the televisit, I do take televisits. However, I'm licensed in Kentucky, New York, now California. So the guidance for televisits is you have to be calling me from the state that I'm licensed in. So I have patients, they continue to see me after so many years, even after moving out of Kentucky. So what they do is if somebody lives in Ohio, they cross the state line, they call me from the car. So they're technically in Kentucky, and they are able to do that televisit because I'm licensed in the state of Kentucky. So there are these ways, imaginative ways that we kind of bypass those. But if you're not close to any of those states, you don't necessarily have to come to me also. There are a lot of very good seasoned net specialists in many, many states. So as long as you see a net specialist, because a net specialist is what they do. This is a very rare cancer. 7 or 8 people in 100,000 people get this. But in my clinic, this is all I do every single clinic day, right? So today I came straight from my clinic. So all 18 or 19 patients I saw today is neuroendocrine cancer patients, right? So over years, we have experience of not hundreds, but thousands of patients. So it kind of just gives us a little bit, that clinical experience to help you navigate this disease better. So you don't have to come to me. You can just go to any nearest net specialist that maybe serving your community. But highly advised at some point in time, it's not a bad idea to touch base with a net specialist, especially if it's an advanced disease, a metastatic disease, because the treatment are evolving. The treatments are getting better and getting more nuanced, and we have multiple options. In past, we had no treatment option. That was a big problem. The latest problem is we have that problem of plenty, which is a good problem to have. Now we have to figure out which is the next best treatment. Should we go for PRRT, cabozantinib, Afinitor, Sutent, clinical trials, liver-directed therapy, surgical debulking, and so many more.
Perfect. Cu64 versus gallium-68, which do you like better?
I think both are very good. They are both very equivalent. If we really get down to physics of it, which is probably not relevant at patient level, at a practical level for me as a practitioner, but at physics level, copper-64 does have a shorter positron range. That means it may be a little bit much better resolution. But this is if everything else is equal. That means the scanner quality, etc. So if you have using copper-64 in a bad scanner and the gallium-68 in a much superior, more advanced scanner, then the gallium would turn out to be better. So these are just radio tracers. So there are a lot of other pieces to the puzzle. The scanner quality, the technician, how good they are in kind of doing the process. But just at the face value, copper-64, gallium-68 is very equivalent, almost same, to nearly indistinguishable. Copper-64 at physics level, maybe a slight edge over gallium-68, but not enough to say, oh, the one is clear winner versus the other.
Great.
I'm trying to be as diplomatic as possible.
You did a great job. You did a great job there. Next question is, does PRRT impact the vascularity of blood vessels?
So PRRT is a radiation, right? It is a physical way to kill the tumor, right? Any radiation exposure beyond a certain threshold will cause the DNA splicing. Literally, it'll nick or slice the DNA. And if a viable cell does not have viable DNA, it cannot reproduce, grow, maintain itself, and it'll die. So be it a tumor cell, be it as a normal cell, it doesn't matter. That's why when there was a radiation leak in Chernobyl, why did people die? Because they got radiated, and that degree of radiation caused the DNA damage, and patients unfortunately died. The same thing is happening to the tumor. Here, in our case, we are trying to preferentially radiate just the tumor, not the normal host, right? That's the whole goal. So the way the PRRT kills the tumor is by DNA damage, rather than not by the vascularity at the mechanism level, okay? So the drug is a somatostatin analog. So when we inject the PRRT drug, it goes and circulates in the body. It tries to find the tumor which has somatostatin receptor. So this somatostatin analog is like a key and receptor is like a lock. So the key binds to the lock, the drug binds to the tumor, and that gets internalized, goes inside the tumor and radiates. And that radiation causes DNA damage. And without the functioning DNA, those tumor cells will hopefully die, and the tumor will either shrink or stagnate. The growth will stagnate. There is another class of drug that we often use in neuroendocrine tumor. One is the recent entrant, cabozantinib, this year. Those drugs are targeted therapies, and they target one of the pathways called vascular endothelial growth factor pathway. This pathway is responsible in neuroendocrine tumor and several other cancers as well to create new blood vessel, what we call neoangiogenesis. Because see, if the tumor is growing and thriving, it has to feed itself. How does it feed itself if it doesn't have blood supply? So it creates that new blood supply by creating new blood vessels. And it does that by upregulating this pathway. So we have understood that, especially in pancreatic net and some other nets. And we have leveraged our knowledge of this VEGF pathway, and the drugs are designed to combat that pathway. So it inhibits that pathway. And when it does that, it slows the tumor growth, right? So those drugs like sunitinib, cabozantinib, lenvatinib, those are the VEGF TKI drugs, and they inhibit new vascular formation in neuroendocrine tumor. So on the mechanism level, they are both anti-cancer drug. PRRT is an anti-cancer drug. These VEGF pathway drugs are also anti-cancer, but they're working at a very different way. Okay, so PRRT mechanistically is a DNA damaging agent.
Great. Okay, real quick, back to Stacy Dunk. She just wanted to know with her her lanreotide versus octreotide versus sandostatin. She wanted to know, how do you know when you should begin shots?
Okay, yes. Thanks for reminding me. That's a great question. So if we are dealing with a low-grade neuroendocrine tumor, like a grade 1 or a low-grade 2, this is not an uncommon situation. And we oftentimes have a patient who was incidentally diagnosed, and we found, okay, the patient has metastatic disease, unfortunately cannot be resected for some reason, it's already advanced. The question is, should we start treatment now or should we wait? So if we are dealing with a low-grade disease, asymptomatic disease, that means patient's not symptomatic. In fact, this disease was just found incidentally. You went to ER for some other reason, they did a scan and they found that you had this tumor. You may consider wait and watch. You may want to see how these tumors are behaving. Why? Because there are times where the tumors might not grow for several years. So if we don't trend out the tumor growth rate, we will never know, right? So there are times where we are dealing with a low volume, asymptomatic, low grade disease that if patient is comfortable, we can do a close interval monitoring and do a scan, let's say in 3 months. And if the tumor is 2 centimeters and remains 2 centimeters 3 months later, then why would you want to start a treatment when the tumor is sleeping? You want to start the treatment when the tumor is not sleeping, it's growing. And what we don't know, and no doctor knows, how long will these tumors remain asleep. The tumor may continue to remain stable for months or years, or the very next scan may show growth. So the right time to start the somatostatin analog is when the tumors are growing in this situation. Now, let's take some other situation. There are tons of patients where I start somatostatin analog right away at time of diagnosis. These are patients where I'm a little worried about aggressiveness of the cancer. These are maybe higher grade 2 or grade 3 neuroendocrine tumors, more aggressive biology, or a lot of tumor. There's a lot of tumor that I don't want to wait and watch. I cannot afford for this cancer to grow any further. So the wiggle room is a little bit less for us. So I want to be more aggressive and start them on right away. Or it's a functional neuroendocrine tumor where the tumors are secreting certain hormones like serotonin and is giving patient carcinoid syndrome, flushing, diarrhea, and other symptoms. So you want to start it right away to help with not only the tumor growth but also with the symptoms. Last but not the least, if the tumor is presenting in a very critical manner, the location where you can't afford for it to grow any further, again, so the presentation, the volume, the grade, symptomatology, functional, non-functional, these are the factors that help us decide, can we afford wait and watch, or should we start the treatment up front? Or sometime these days we not only start sandostatin or lenalidomide, sometimes we add PRRT to it up front if it's a much more aggressive variety of tumor like a grade 3. So it all depends on it. So it's not a very easy one size fit all answer.
Perfect. We have another one. The recent RETNet trial showed that chemoembolization had a lower rate of adverse events. Adverse events than bland embolization, while offering similar levels of tumor control. Has this impacted your institution?
I'm not certain about this. I'll have to revisit this. I don't know if it was statistically that different. You know, that the chemoembolization had lower rates of adverse event with bland. I think institutions do both. At our institutions, we do both. We really leave it up to our interventional radiologists, those who are proficient in one technique versus other. What we do know, or what I have personally done, is I've minimized use of Y90 in a lot of patients, because in the era of PRRT, I try to minimize the radiation exposure to liver. Having said that, there are some great candidates for Y90 based treatments. So if it's a very specific lobar disease, and radiation sometimes works really well for that. You know, there is some role of it, Y90 based embolization, but I've slowly scaled back. I'm a big believer in bland embolization. It works quite well in a lot of my patients, and I know several net centers that do that. Same thing with chemo as well. I think we've done it. What we, I think, learned is the DEB taste, that's too toxic, and we don't do that anymore. But I'm not 100% sure. I'll have to study it. There was no clear winner in REDNet between these two arms. So I think both of them are fair game. And that's why you don't see that there is just one practice that this is the best way to embolize. You know, so in fact, my personal experience has been very favorable when it comes to the bland embolization. When I was at University of Kentucky, we in fact did combination of everolimus plus bland embolization, and this is in public domain. You can check out the data. It looks pretty impressive, but it's a single institution study, so with that caveat. So you have that ability to combine bland embolization with systemic therapy, which with chemoembolization, there is risk of too much of additive side effects. So you'll have to kind of do it and give the break from the systemic therapy during that period. So I think both are reasonable. I'll try to revisit this data. You know, Dr. Mike Sulin, he is the PI of REDNet study. He actually reached out to us, and he has a follow-up study that we are participating. We are one of the 4 centers that Dr. Sulin from UPenn invited. So we are participating in his next study, where we are combining Y90 with CAPTEM in certain select PNET patients. But yeah, I don't recollect that there was a clear winner between, you know, chemoembolization versus bland in terms of adverse events. But you know, I may be wrong. I'll have to revisit this.
Perfect. Great. Cheryl Goldfarb Greenwood is saying she's a multifocal lung net with 1 biopsy via bronch, grade 1, Ki-67 is greater than 1%. I'm sorry, less than 1%. Mitotic count 1%, well differentiated. N0, M0, presumed dip netch. Can staging be designed to each net versus assigning stage 4 as per guidelines?
All right. So, Mike, homework for you. You need to, next time we meet, tell me what DIPNISH, the full form. It's diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. You got to memorize it next time.
I'll work on that.
All right. So, DIPNISH is a very understudied and an enigmatic entity. Some people think it's a precursor to lung nets. Some people think that it is an actual neoplastic condition. We have seen it both ways. Basically, it's small neuroendocrine tumorlets, less than 5 millimeter, and it's a pathological diagnosis. So a pathologist makes this diagnosis based on the biopsy they see under the microscope, and it has to fit in that criteria. If it invades the basement membrane, it's more than 5 millimeter, then it actually qualifies to be an actual typical carcinoid or lung neuroendocrine tumor. But if it's just shy of that size criteria and the way it looks under the microscope, they then classify as DIPNISH. Now, will all DIPNISH evolve into a full-blown neuroendocrine tumor, or some of them? We have seen the case reports allude to both possibilities. Some patients with DIPNISH will just stay dormant like this for the rest of their life and it doesn't bother. It's an incidental diagnosis. So thought of it, consider it like a benign pre-neoplastic condition. In other cases where DIPNISH has rapidly evolved and became a full-blown lung nets and needed the full spectrum of the treatment. I have quite a few patients of DIPNISH that I treat in that spectrum where it's not the benign kind, where it kind of evolves and morphs into a lung net, or was present along with the lung net as well. So sometimes patient would have a bronchial net along with some not tumorlets, which are DIPNISH, right? Now, it's a good question regarding how do we stage if there are multiple DIPNISH, right? So unlike other lung cancer where we have one primary tumor, is it a metastatic site in the other lobe? Here in DIPNISH, usually you can have multifocal disease. So you can have multiple spots which are all early stage. But the question is, the reason why we stage these cancers is because it impacts the management. If it's an early stage, usually you want to do resection or do the surgery. But there is a limit how many surgeries you can do, especially in the lung. You have a limited real estate, right? So if you take too much lung away, you're not going to be able to breathe. So even if you have two spots or the multiple spots, but they're all, we think, early stage, they are sort of metastatic because we can't resect all of them. It's just going to be too much of resection. You won't have enough normal lung tissue left to function normally, breathe normally. So this is where it gets a little bit of a gray zone. So if my philosophy is with this DIPNISH type of pathology, which is rather slow growing indolent disease, this is a surgical disease in most cases. You need to really have a good cardiothoracic or thoracic surgeon on board and see if they can cut it out without collateral damage, minimize novel lung parenchymal loss. And if that's possible, it doesn't matter if it is more than one area or few spots. But if it's going to, you can have an early stage, but multiple of them, and the surgery might yield more harm than any benefit, then in that case, despite having early stage disease, it might not be worth going for resection. So it's something that you want to discuss with a good thoracic surgeon. And staging at that point is sort of a moot point. You have to understand your disease burden and can it be resected or not, regardless of if it's technically stage 1 individual lesions or a stage 4. Yeah, that's what I would suggest.
All right. We got 2 more, and we're going to wrap it up here. The first one is from Julie Michael. You mentioned the efficacy of the kidney is a consideration for PRRT. Can you speak to this in more detail? And I have CKD stage 3A. What stage would someone not be a candidate for PRRT?
Right. So, yes, so that's a good question. So what I meant was, if somebody has renal insufficiency means some sort of kidney problems to begin with. Like you mentioned, you have a chronic kidney disease stage 3A. You have to be very cautious about proceeding with PRRT. One of the known possible complication is renal problems. Now, in a patient who has no CKD, no kidney problem, no diabetic nephropathy, no hypertensive nephropathy, no kidney problems for any other reasons, normal kidney function, the chance of us getting a kidney problem from PRT is extremely low, very, very low. I've treated tons of patients, I've not seen that. When I have seen this is when patient had some kidney problems to begin with. You got to be very cautious there. Because what you can do is you can end up patient in dialysis. You can really hurt the patient, right? And that's the reason why when we do PRRT, especially with Lutathera, patients get amino acid infusion to protect the kidneys. We don't want that drug, the radioactive drug, to hang around near the kidneys for long, because the longer they stay around the kidneys, they radiate the kidneys and it can have a detrimental effect. So if somebody's kidneys are not best to begin with, this is definitely a concern. Now, there have been, fortunately, a couple of very good publications that have reassured us that patient who has some renal compromise at baseline, even those patients can have good outcome and can tolerate PRRT well without significant detrimental issues. But so a normal kidney function, the GFR is usually over 60. And these retrospective studies have suggested that you can maybe consider PRRT all the way up to 40 of GFR. So somebody 40, 45, with close monitoring and make sure that patient's tolerating, you can probably do it. I would get very nervous if it's below that. And I would only do it if that was the only option left and patient understands that, hey, at worst case scenario, we may kill your kidneys, you end up in dialysis. But that patient understand that was the only way to save patient's life, because the progressive cancer would have otherwise been more of a problem. So the GFR is what I usually go by. 40 and 45 is usually my lower limit of comfort level. Below that, I get very, very nervous in treating, and patient needs to understand the risk of kidney damage is pretty real. You got to watch very closely how things evolve. And sometimes you might have to get creative with the dose. You may have to lower the dose of radiation, etc. Just because we don't have safety data. The trials that test Lutathera or PRRT all included patients with healthy kidneys. So when you treat in real world patients with unhealthy kidneys, you're really making it up. We don't really have good evidence to guide us at how patients will do with CKD3 or CKD2, etc. So there is some reassuring data with some renal insufficiency, but you got to be cautious, okay?
All right, and the last one, liver embolization. What is the approximate recovery time?
Yes, good question. Sort of depends on the type of embolization. I think the bland embolization, in my experience, has the shortest recovery time. But all in all, most patients, in my experience, often recover 2 to 3 weeks into the treatment. Radiation Y90 base takes a little bit longer because they implant the beads and it radiates the tumor over days, and patient may have some fatigue issue going on a little bit longer. Bland embolization is very quick. Now, unless patient specific, the procedure, there was a complication, there was a bleeding, or the beads went into the wrong place where they're not supposed to go, or there was just an individual anatomic issue, or it was a very big tumor and there's a lot of tumor shrinkage. And when tumor dies, you're going to have inflammation and pain. So these recovery times can vary based on individual patients and how, the degree of embolization. But for most patients, I expect them to be really feeling well within a week with support of pain medications and monitoring, definitely within 2 weeks for sure, with some degree of fatigue and mild lingering pain going up to a few more weeks.
Awesome. Awesome. Well, I want to thank everybody for joining us. Dr. Chauhan, thank you so much for joining us and just giving us all this information, answering everybody's questions. We know you've had a long day. We're going to let you go. Everybody, please make sure to go over to netcancerawareness.org to find out everything that we're doing. We're going to be doing another one of these in a couple of months. It's going to be another good one. And, all the great events that we have going on. Again, September 21st, if you're in the New Jersey area, we will be in New Brunswick, New Jersey. Go ahead over to netcancerawareness.org for more information on that. And on social media at netcanceraware. And that's really it. Everybody, thank you so much for joining us. And we will see you next time.
Thank you, Mike. Thanks for the opportunity. Good evening, everybody. Take care.